Welcome to Every Possible Angle, where we have the honor of speaking to people that are doing really interesting things, things that would once be considered science fiction. Really honored and privileged to talk to these guests. I'm joined by Kalina Sconsert on our team here at Paragonix today to speak with Dr. Shannon Tessier, who is the associate professor at Harvard Medical School at the Center for Engineering in Medicine and Surgery, as well as Dr. Asishana Osho, who is the associate professor of surgery at Harvard Medical School, as well as a heart and lung transplant surgeon. Today's conversation is going to cover a number of topics. We're going to talk about what the latest research in the field is showing and how this can help a lot of patients. So, without further ado, thank you both for joining us today. So, just to get started, one of the interesting things about transplantations is the journey that led you to what you do today. And so I'd love to spend a little bit of time understanding what each of your journeys are. When did you first learn about the field of transplantation, and what was really the hook, if I can, that really got you to kind of stay and continue to be in transplantation? Dr. Osho, maybe let's start with you.
Sure. This was not really the plan. In fact, being in surgery wasn't the plan from the beginning. I grew up in Lagos, Nigeria, and wanted to treat the things that I saw. So malaria and HIV. Once I said it's go to medical school were the things that I wanted to treat. But then I did some time on those services in med school and didn't enjoy it. And I was looking, and I was invited by a cardiac surgeon to come to the operating room to see the work, and I fell in love there. The physiology, the technical aspects really pulled me in. As I explored that as a new option, I then found a research mentor who was a transplant surgeon, and started to do a lot of database driven transplant research. Again, loved it. Really thought there was a lot of opportunity to move the field forward, and then in some ways the research or the investigative aspects of my life then drew me into a clinical practice that included transplant surgery. Sometimes it feels like this has always been the plan or always been me, but there's been some change to get there.
Dr. Osho, do you remember what that first case was that you saw that made you fall in love with it?
Yeah. It was a cabbage. Yeah. Surprise.
And Dr. Tessier, how did you get to where you were? And also, does your research focus on transplantation only, or does it have a broader focus?
Yeah, so I think similarly to Dr. Osho, my beginnings, I didn't realize I would end up here, although I think there were always some undertones there. So when I started in biology, I actually didn't know, I actually wanted to go to medical school first, but then in my undergrad, then I started in a research lab. I come from Canada, so I did my research in Ottawa. And the mentor that I had at the time just was so passionate for research, and he just totally captivated me. So I fell in love with research, decided to do my master's, and then sort of never turned back, decided I wasn't going to go on to medical school, and instead completed my PhD. I was in a very basic science lab. We were studying animals that survive extreme conditions. So these can be like hibernators and freeze-tolerant wood frogs, etc. Um, However, I realized that these applications for these animals had lots of important lessons that could be used to improve many aspects of medicine. And one in particular was organ transplant. And actually, I was looking back on one of my fellowship grant applications, and I had written in there, all of these things could be applied to organ transplant. So I think there was like some push that brought me to transplant. Then I wanted to come to a hospital to do my postdoc. I really wanted to apply these sort of basic biology experience in a more translational setting. And sort of that's where I came to Mass General, and then got connected with Dr. Osho through a common mentor of ours. And I guess the rest is history. In terms of my lab, a huge focus is definitely working in the transplant phase, in the transplant field, and of course, Dr. Osho and I have a joint lab where we're sort of building these specialized facilities in transplant. But I also study broadly other aspects of suspended animation as well as preservation and cryopreservation.
Fascinating. I think both of your journeys are very unique, and it's really interesting to see how you are now working together at Massachusetts. Can you tell us a little bit more about the lab that you share, kind of what the research focus is, a little bit about how it started, and what are some of your long-term goals?
I'll let Shannon start. I'm giggling though because of some of our, we've worked to name the lab, and there's been a lot of fun conversations around that. But I'll let Shannon start.
Um, yeah, so Dr. Osho and I have been working together now for 3.5 years, I
Isn't
want to
that
say.
incredible? Huh?
Yeah.
Wow.
And, we started with, as well with Dr. Rabi, who's now at the University of Toronto and United Health Network in Toronto. So, we sort of started in a completely empty lab space. So there was just a, bench. And, both of our separately trained trainees, and we sort of just brought them together. Together, we built some specialized facilities for ex vivo perfusion. So a central part of our work in transplantation involves the use of machine perfusion technology. And so now we have, you know, built up a lab space where we have multiple perfusion devices for across multiple systems. So we have a small animal facility where we have up to 6 perfusion devices, and also a large animal facility which also does human organ perfusions as well. Um, so Shauna, do you want to, or Dr. Osho, do you want to add to that?
No, God, son of yeah, he's us absolutely. No, it's really been a wonderful experience building this alongside Shannon and like you mentioned, Ali Ravi, who isn't here. Um, the one of the most fun thing is we have lab members and learners of all different levels. We have some folks in undergrad, we have medical students, we have folks in their master's and PhD programs, and as well as the sort of the workforce, which is our range of absolutely incredible postdocs and PhDs who help to keep the lab running. But you can imagine that amount of just energy, that degree of input from people really helps us to maintain vigor and excitement through all these projects that we're doing. I can't emphasize enough what Shannon has said in terms of the platforms, the multiple systems for organ perfusion, because in addition to helping us answer specific questions and tackle transplant in general, this creates just a wonderful platform to study anything that requires isolation of organs. And it's such a unique way to really see the impact of a therapy or a drug or changes in conditions on a single system, and the power of that is immense.
Yeah. Yeah, definitely. So Dr. Tessier, from your background in this basic science lab, what was the evolution to kind of expand into all of these different platforms that you've described and this specific application to transplant?
Yeah, so I mean, like I sort of kind of alluded to, the sort of these, we've been studying these animals that survive extreme conditions, and it was always clear, even from an early on, that a lot of this sort of stresses that they overcome have many applications in transplant. And so as we were studying these things in the lab, we were realizing that we had sort of discovered a couple of mechanisms, but also potential molecules that we could use to try to overcome some of the central stresses that an organ will survive through its transplant journey, including ischemia reperfusion. So as we were looking to sort of set up this lab and expand these, discoveries into transplant, I was talking to one of my mentors who said, well, I know these other transplant surgeons. I think it worked out really well because we were all, the timing was really, really good. Dr. Osho and Dr. Rabi were, just, uh, you know, either had just launched their clinical practice or were about to, were looking to really set up their research space. So I think we just collided in the perfect timing. And so it's a unique experience whereby, I can take our discoveries in the lab, share them with Dr. Osho and Dr. Ravi. They have their important experiences on the clinical side. And then together from both of these angles, we can think through, new approaches to try to solve these problems.
Yeah. Yeah, so I know you've done some really exciting work recently in DCD heart, and we definitely want to get to that. But I'm curious, what were some of the earlier experiments that you were running in the early days of this lab? Can you share any examples with us?
Yeah, so like before we combined forces with Dr. Osho and Dr. Rabi, do you mean, or just as a team? What were some of our earlier?
As a team, yeah, I'm curious about the first kind of applications to transplant.
I would say maybe Dr. Osho, what do you think? Would you say maybe the assessment paper would probably be a really important one that sort of really set the framework for a lot of the? Yeah. Do you?
Think so. Yeah, I think so. And perhaps even the as I think about the first things that we did, cellular versus acellular perfusate was something that came up. So uh, during some of our initial conversations, we were exploring both, heart and lung perfusion ex vivo. And one of the striking differences is much of what we do in heart perfusion is blood based, or what we call cellular, and in the lung space, much of it is completely acellular. And Dr. Tessier had already started to sort of think through some of the challenges that you would have with having a blood-based solution for heart perfusion. So some of our early work compared these two approaches in ex vivo organ perfusion. And I think that really set the stage for answering questions, beyond that.
Yeah, I think the second sort of major, I guess, development as a team was to develop ways that we could properly and functionally assess our outcomes. So you're doing experiments with these organs that are outside of the body, and you need to have good metrics to be able to know whether your therapeutic or your treatment or your experimental protocol has been effective or not. Um, and that needs to occur prior to transplant. We need to know that the organs are healthy before they're transplanted, of course. So the team also developed a machine perfusion sort of device that was able to perfuse in a way that we could assess the function of the heart. So this is a loading protocol where we load through the left side of the heart, and it allows us to assess, ventricular function. So I think that sort of platform, like Dr. Osho mentioned, is a platform that we apply in many of our studies. So I think ended up being a really good team building experience. It also allowed us to develop our expertise on the surgical side with large animals and also human hearts too. And then all of these things sort of, really laid the foundation for the infrastructure of the lab, and the trainees too.
Yep. And I think maybe just to take a one step back for some of our viewers who may not be familiar with the organ preservation and how that's done clinically. From a clinical perspective, Dr. Osho, can you briefly provide context into how organs, specifically hearts, used to be preserved and where we are, and what are some of the exciting things that have happened recently and that you're looking forward to from a clinical perspective, to give us context into why the both of you set up this research lab with Dr. Ali, and to give us some context on what you want to do next.
Do you have another 2 hours?
Yes.
Well, let me see how I can be brief here. So, I guess starting with the really traditional parts of heart transplant, we had to do everything quickly because when the heart was out of the donor on the way to the recipient, it essentially was kept on ice. And in that paradigm, in that life, you can imagine if there's a little bit of ice on a different part of the heart, or it's not uniformly cooled, that there could be differing effects on the heart. And we found in our work that you were limited to about 4 hours, and anything beyond that, or even getting up to 4 hours, meant that heart struggle when you tried to use it in the recipient. In the next progression of that has been really exciting for the space, and really already shown to extend the preservation period using systems that uniformly cool the heart and also keep it at temperatures that are more physiologic instead of or that are more protective, instead of the ice, which is, somewhere around 0 degrees, but some higher, some lower, all over the place. Uniform storage anywhere from the sort of 4 to 8, maybe 4 to 10 degrees. Some of the work that's been led, of course, by Paragonix and Sherpa Pack. So that, the data is clear there that doing that has really extended the duration of time we can protect the hearts, as well as the quality of the heart that you get afterwards. And then the next phase of things is really pushing things even beyond that. And this is where I think perfusion comes, because you then move from just the static storage to perhaps having these hearts working to some degree while they're being transported, which gives you then the opportunity to evaluate them. And then one step further is the opportunity to potentially treat them and make them better. Put in things that can make the post-operative, the post-transplant, the life of that patient easier down the line. And without going into too much detail about each of these individual things, I think that opportunity is really incredible, and I think provides a lot of excitement in our space.
Yeah, and just to add on to that, I think the other there's a lot of parameters when you're considering a heart for a patient. One of the ways that, as the way you look at the donors is if it's a donation after brain death or donation after circulatory death. And just to tie back to the research that your team is doing, the both of you are doing, traditionally, can you share how DCD hearts were procured, and with the research that you guys have started to publish on, how we may be procuring and preserving DCD hearts in the future?
Yeah. I think it's sort of very interesting and incredible how things have gone back and forth in DCD. Some of the earlier transplants ever done were actually DCD procurements, and for those who don't know quite the difference, the standard way that we've procured hearts is called donation after brain death, and in essence, it's when a donor meets the full clinical criteria for brain death. And this is sometimes by ultrasound, by clinical testing, by apnea testing, things like that. That donor is officially considered brain dead, and legally, we are allowed to go to the operating room, prepare things, and take heart out under very controlled circumstances. In donation after circulatory, or sometimes called cardiac death, it's a little different. That donor will typically have a very devastating brain injury, but just falls short of meeting the criteria for brain death. Doesn't quite have the ultrasound findings that you need, or the apnea testing that you need. But everybody, has a high suspicion that when they get to the operating room, if you withdrew life-supporting therapies, especially the ventilator, that patient would lose their respiratory drives and pass away organically, or essentially have cardiac death. So in those situations, we go to the operating room and we withdraw the life-supporting therapies, and then you see if the patient passes. If they do, you can then take that heart, or take the organs in general. The challenge there is that during that period where life-supporting therapy is withdrawn, the patient, the heart, the whole organs are not being perfused. So there's some concern there that there is some degree of change or damage to the heart that is irreversible, and may affect whether or not it's acceptable. So the way that we originally started to do that, at least in the U.S., was to very quickly open the chest, very quickly start a preservation of the heart, and then cut it out and put it in a pump to get a sense of what it was doing. We had a few assessment tools that, including lactates and just seeing how the heart squeezed, that helps you decide. The alternative to that was to put the patient on ECMO, which is a version of life support, after they passed away. There's a lot that can go into the conversation there about ethics and whether or not you're restoring blood flow to the brain, on and on like that. But that approach allowed for animation of the heart inside the donor, and full assessment techniques there, including echocardiogram, things like that, which provided another alternative, but also has some challenges. Um, the future of where to go for DCDs is very exciting. The technology for ex vivo perfusion was using sort of warm blood solution that you collected from the patient, and frankly comes with a certain degree of cost that is not necessarily available across the board. So future ways to do this that remove or change parts of that, or provide other opportunities for adjusting the organ are just really exciting.
And so you walked us through the cardiac death process a little bit. Can you explain why it's so uniquely challenging for heart transplant? And maybe, Dr. Tessier, from a scientific perspective, why it was seen as so challenging, and how your new research might be kind of bringing more insight to those previously held assumptions of, needing immediate reperfusion.
Okay, maybe I'll let Dr. Osho handle the first part of that question,
Sure.
and then I can jump in for the second. What do you think? Is that okay, Dr.?
Yeah, sounds good. That's yeah, glad to. I obviously I think of heart as not like it's more special than all the other organs, but it is. Um,
Aren't
and
you also a lung transplant surgeon?
all of my kids are equally special. But I think that the cardiac metabolic rate of the heart and just the needs of the heart are such that even short periods of ischemia that we see around DCD transplantation could be incredibly impactful on the outcomes that you have, and that raises unique challenges for how we manage this, how we assess it, and things like that. There are challenges in DCD lung transplantation, for example, and certainly the liver specialists have developed algorithms that help them address it as well. So it's not just that the heart. I think DCD transplantation in general is complex, but I think of all the organs, the heart is uniquely susceptible to the ischemia, and in ways that make it critical to either be confident that the heart will work or assess it to get to that point.
Yeah, and then just to sort of piggyback on that, I think it's interesting because, like Dr. Osho explained, sort of DCD hearts currently, at least the standard, is to go straight to normothermic machine perfusion. So from DCD, you go to immediate reperfusion and sort of preserved at active metabolic function at more physiological temperatures. And the data there looks really promising, and there are some sort of modest extensions in preservation duration. I think because of that, there was, it wasn't really clear if that was the only way that DCD hearts could be preserved. And so in our team, we really wanted to understand, do DCD hearts really need to be preserved only by normothermic machine perfusion? Or can we have this system where we would do an intermediate, time of hypothermic or other colder temperatures for preservation, and see if we could get, interesting or similar outcomes. So I think just important, though, to be clear that this is a limited study. But what we did was we looked at we had a DCD model. This is a pig model, where we removed those hearts and stored them at hyperthermic temperatures. We used 4 degrees Celsius for increasing durations. So we had a very short duration, and then we had sort of 2 longer durations for 5 hours and 7 hours. And then what we did was, after that preservation duration, we reanimated those hearts, and using our technology to look at functional outcomes, and in particular sort of ventricular beating, we were able to assess the function of those hearts after hypothermic. So again, this traditional way of normothermic, this was completely different in terms of going to deeper colder temperatures. And I mean, personally, from a scientist perspective, I was surprised that it didn't matter how long we kept those organs at hypothermic temperatures. I think we went up to 7 hours. That those hearts reanimated and showed similar function to the DCD hearts that were not preserved using hypothermic temperatures, but right after DCD or right after the procurement were perfused immediately. So again, this is a very limited study, but I think it was eye-opening to us in particular that maybe the only solution is not straight to normothermic machine perfusion. And I think this is important because, as Dr. Osho was talking through sort of the differences in hypothermic preservation versus normothermic, there are just fundamentally different advantages and disadvantages to each of them. Hypothermic preservation is simpler, whereas normothermic perfusion, you have more access for functional assessment and therapeutic opportunities. So they're just different. They're not necessarily competing. And if we can leverage the advantages of each of these approaches in the right context, so that we can gain the advantages, I think it's important. And just to kind of give you an example of how that can be relevant, I'm thinking of recently, Dr. Rabi performed some of the first DCD heart transplants in Canada, which was really exciting. And in Canada, they didn't have access to the normothermic machine perfusion, so they used a hypothermic preservation strategy or a colder preservation strategy. And so, this is just one example, but there might be instances where applications of hypothermic preservation would be easier in the sort of clinical applications rather than the normothermic machine perfusion. But maybe I'll knock that back over to Dr. Osho to comment on the clinical aspects of that.
Yeah, absolutely. I think sort of a great way to bring this study in. It's particularly timely as people are sort of looking for alternatives to immediate normothermic reanimation of the heart. I'm sure many have seen the work from the Vanderbilt group recently about their version of this. I think they called it re-up ultra oxygenated preservation, they called it. But in essence, they use a blood-based solution and donito and some oxygen into the root directly after taking a DCD heart without any perfusion at all, any sort of active ongoing perfusion at all. That is their protection phase, and then they implant those hearts, and so far the results have been good. So I think this is when science is most exciting, when you're realizing that you've got all these different approaches and all these different tools, and you're trying to find what's necessary strictly, what's important, and what might be applicable in different phases. You imagine the ultimate state will be something really exciting that can extend the duration of preservation, where we take the hearts and we store them for 7 hours at 6 to 8 degrees, and then you perfuse them for a couple, and then you can store them again for 7 to 8 hours. So heart transplant is no longer this thing where you're calling patients in and calling everybody in at 2 a.m. in the morning and ambulances and red lights. It's as close to coming off a shelf as one could get.
Yeah, it's similar to kind of what the options you have on the lung side. Is that what you see?
Getting
hearts?
to that, but perhaps even beyond that.
Okay.
There's no reason why old organs can't get to a state where these are semi-elective operations.
Yeah. What's really fascinating, Kalina and I have, are both engineers by background. We've been in this space for about 4 years or less. And I remember in 2021 when I met Dr. Osho at a few different places around the country when we were looking at different prototypes for next generation systems.
Yeah.
I believe at that time.
Don't describe the hotel.
Yeah, let's not discuss where we met. Los Angeles,
rooms.
Boston, all over the place, and what kind of settings we met in. But I remember that back in 2021, even I would say 2 years ago, 2023, nobody would have even imagined taking a DCD heart without reanimation and then transplanting it. And then here we are in 2020, end of 2025, where I feel like we're just starting a new era of preservation and DCD. Would you agree? I know you've been in this space for much longer than I have.
And it's certainly it's great to see it in clinical practice. We've been thinking a lot about it in the lab, and whether all of that was really necessary. And honestly, some of it came from just the volume of stuff and technology that is needed to travel with you to get a heart. I was during my last year in training, I was spending, a couple of days a week, flying out to California, but you've got three people and it's really expertise, or high expertise individuals with a lot of equipment, flying on a appropriately sized private jet that had to stop to refuel somewhere. I mean, the financial outlay to do this work was just growing and growing. And I think, understanding or realizing that there might be options to even simplify this considerably is really exciting.
So this is definitely the research that we want to dig into. And if I were to summarize what we've talked about so far, it's this idea that DCD hearts can actually tolerate that 5 to 7 hour window of controlled hypothermia at 48 degrees before reperfusion without losing function. And Dr. Tessier, you mentioned that the results kind of surprised you at first. Can you talk more about that? What was your original hypothesis, and what did you expect to see versus what you actually found?
Yeah, I mean, I think there's a couple things to think about. Like Dr. Osho mentioned, I mean, I think we've been sort of trained in our thinking that sort of, straight to normothermic machine perfusion is the sort of standard and the norm for DCD. And that still works great. And this is not to necessarily to replace that. But I think that just kind of that you always have that, standard in your mind. And then I think, part of the reason why we designed the study is so that we would have a shorter hypothermic duration and sort of a longer hypothermic duration, is the thinking that over time we would see that loss of function. And I do think that we would. So, if we start going out into longer cold ischemia times, that eventually, of course, we will hit that point where it's not feasible to do to reanimate and not see similar outcomes in terms of function. But it just was surprising that even after 7 hours, which typical out of body time for a heart that's preserved at hypothermic temperatures, for a DBD heart.
Mm-hmm.
And again, we have to be cautious that this is a pig model. This is not a human model, and there can be differences in tolerance to warm and cold ischemia. But anyways, we were thinking that longer hypothermic duration, we would potentially see some decline in function, but we didn't. And in fact, the function was not statistically different, even from the ones that went through a very minimal cold ischemia time of less than an hour. So really, it doesn't show us where that end is, like how far we can go, but certainly emboldened us in realizing that it could be feasible with hypothermic temperatures.
So, Dr. Tessier, just to build on that, you mentioned this was studied in a pig model, not obviously with human hearts. Just for context, are pig hearts more or less tolerant to ischemia, and is there an easy way to understand, let's say 5 hours in a pig ischemic heart is equivalent to what in a human heart?
Yeah, it's a really good question, and we've talked about this a lot in the lab, trying to build the sort of expertise, but also sort of the standard controls that we need to be able to match these to what would be the equivalent ischemia tolerance for a human heart. I think there's a couple of challenges in that because these are obviously closer relationships. I mean, there's not as much genetic diversity in these. So I think that's one thing. We are using pretty young animals.
Mm-hmm.
So I think that's also another thing that we have to take into consideration. There is some feeling that the pig organs might be a little less tolerant to warm ischemia, which is something we're always thinking about. So, for example, our DCD model with our work used a 20-minute or just like a 19-minute warm ischemia period. Although I think there has to be a lot more work in the field to really make sure we standardize this across. We've done a lot of work in the smaller animals, in rodents, to try to match those times. So just to give you an example, for our heart preservation or hypothermic preservation with our small animal model in the rodent, we estimate that they have a enhanced tolerance to cold ischemia. So like Dr. Osho mentioned, 4 to 6 hours, really the maximum for a human heart. A rodent heart, we believe, again, we haven't sort of done an orthotopic transplantation to confirm this, but more in the range of 12 to potentially even 18 hours with transplants, post-transplant survival. So there really can be quite substantial differences in the tolerance to these different stresses, and I think it's an important consideration. So thanks for bringing that up.
So just directionally, if I understand correctly, let's say we wanted to ultimately go for 10 hours in humans, cold ischemic time. What type of in terms of length of time for a pig organ would you have to study? Would it be more than 10? Are we talking 15, 20? Are we saying less than 10?
So are we talking about a DCD model, or are we talking about a TBT
We
model?
we could talk about both. I'm actually really curious, like,
Ah,
if 10 is an arbitrary number, but like,
yeah.
would it be a 15-hour DBD pig heart that is ultimately closer to a 10-hour in a human, or vice versa?
Yeah, I think, I don't know, Dr. Osho, if you also wanted to jump in here. I don't want to dominate.
I think it's a hard question to answer. It's a great question, but it's a hard one to answer because there are different factors to it. So I think that the smaller hearts in the small animals, for example, you can cool those more uniformly faster. So you can get them to the stored state faster. So that may push the tolerance in one direction. But the specific cells of those hearts are a little more sensitive to the warm ischemia in the first place. So it's now you've got a little push in one direction and pull in the other one. So it's hard to say, you know,
Hmm.
8 hours means 10 hours here or things
Got
like
it.
that,
Yeah.
because they will vary by specific condition.
That's an
Um,
interesting point about the size of the heart. I hadn't considered that, and maybe the implication that it has to do with the speed of cooling or the speed to
Mm,
uniform cooling. That's a really interesting point that I hadn't thought of, and especially on the front end, right? As you suggested, when it's in its most vulnerable state after procurement,
Absolutely.
still warm, inconsistently warm.
Yeah.
It's really interesting.
Yeah, absolutely. And
mm,
I think one probably is a thing that organs don't love is the differential rates of temperature change. Because they need different things as like at the different phases. They need different things when they're being preserved. They need different things when they're being woken up to be assessed. They need different things when they're being reanimated in the recipient. And I think that it's just so variable along the different organ systems or animal systems that it's hard to know.
Yeah, I think no matter what, if we're interested in targeting a 10-hour cold ischemia time for a human trial, we should be aiming for much longer and showing success, at least in the pig. So either way, I think that the longer we can get in our pig model, and then ultimately the best way to confirm success in any transplant experiment is to perform the transplants. And so I think that's a big push in our lab because the study we talked about so far has all been assessment ex vivo. And so I think if you add that on, we think that there will be correlations with those functional assessments ex vivo and transplant success. But until we've sort of shown that with transplant success, it's really hard to be sure what those time matches are going to be with human, and also very sure that, the technologies we're developing and these sort of outcomes that we're looking at are, certainly will lead to long-term outcomes, successful long-term outcomes in transplantation.
And we've talked a lot about your functional findings of this study in your model, but there were some additional findings that I was especially interested in that I wanted to make sure we covered. You also looked at inflammatory markers and other markers of deeper molecular mitochondrial health. Can you talk more about your findings in the cold storage first arm versus the immediate reperfusion arm?
Do you want to handle the inflammatory one and I can do the mitochondria,
Yeah,
Dr. Osho? What
yeah,
do you think?
yeah, absolutely. So I think this is a hallmark of the way we think about doing this work. Is that it's not that you just take one particular thing that you look at afterwards, whether this is the pressures that we're getting or views of how the heart is squeezing. It's really understanding the entire system and how it's changing with the modifications that you make. So the functional assessment was one of the things we developed early on and anchored all our work. But then, looking at a full battery of pro-inflammatory markers or inflammatory markers in general, exploring proteolysis, using mass spec and other techniques to understand the overall multi-omic milieu that we create with these analyses. And then, like you mentioned, that there's so much interest in understanding mitochondrial health and how that changes with transplantation, that it just made sense to include this in the work that we did. So to hone in on the inflammatory milieu of things, so we were very interested in seeing if varying degrees of cold hypothermia resulted in a range of inflammatory responses when you return to normothermic perfusion for those hearts. Some of the work that other people have done has really shown that normothermic perfusion itself generates a really massive inflammatory response, first from the heart and then from the recipient. So we wanted to see if there would be different ranges of this inflammatory response, first from the hearts that didn't have a lot of storage time to those at 5 to those at 7 hours. And our data, it did not demonstrate that there was any change in the inflammatory response immediately after you perfused the heart across those different temperatures, which is good to see because you wonder if the heart sustained any kind of damage by being perfused for longer periods. You would expect that when you reanimate it, then the inflammatory changes would be higher, but we didn't see that in this particular context. We also looked at a wide range of both pro and anti-inflammatory cytokines that would really be released at any period. And again, it didn't show a massive response. So it's still like the heart was working harder to protect itself or working harder to mount its inflammatory response from either the early or the later perfusion runs. Now, the final, truth is that we need to see this, like Dr. Tessier was saying, in a transplanted system, so that we know the contributions from other organs in the body to this new heart across different hourly durations of freezing. But at least with what we have so far, it's been encouraging in the inflammatory spectrum.
Yeah, and I think just to add on to that in terms of the mitochondrial outcomes in the study, and sort of programmatically, I think our group is very interested overall in mitochondrial health and the way that mitochondria can be used both as a tool potentially for diagnostics of, is this organ, suitable for transplant or not, like Dr. Osho mentioned in the context of sort of other biomarkers and diagnostics as well, but also as a sort of mode to better understand ischemia reperfusion injury in preserved and reperfused organs. And so for those reasons, a lot of our studies will look at mitochondria, and mitochondria are important because they really hold a central role in the molecular pathways that can really exacerbate ischemia reperfusion injury. And, there's also really exciting studies out there, too, that are looking at, mitochondrial transplant, for example, in the context of solid organ transplant, including hearts. Some really exciting work being done there that shows that, just by replacing damaged mitochondria through the sort of mitochondrial transplant process, that you can really significantly improve heart function. And so I think it's an important marker that we're looking at. And so in this study, again, looking at the sort of minimal cold ischemia time versus the sort of increase in cold ischemia time, we're really happy to see, happy and functional mitochondria that also looked anatomically um, preserved. But we also had looked at other metrics like length and width. We also have another tool where we use a laser-based approach to measure the function of mitochondria. We call it the 3-RMR. This looks at the redox state of cytochromes in the electron transport chain. And when we measure those during reperfusion, those mitochondria are functioning properly as we would expect them to function, with no differences as compared to that sort of lower, shorter cold ischemia time. So I think that was also really exciting to see and reassuring that our mitochondria are healthy as well.
How far do you think we are from using this technique that you published on in the clinic? In general years or months? I know the space moves fast. Um, so I'm just curious, is it something you think we'll see in 2026, 2027 timeline?
Well, Dr. Osho, why don't you were talking about the Vanderbilt study, I
Yeah,
think.
I
So I think that's not exactly this.
Right.
There are important differences in our protocol versus theirs. But I think it depends what you're asking, like conceptually using hypothermic storage for heart
Well,
transplantation.
well, I guess your approach, your team's approach of hypothermic preservation of a DCD heart for extended periods of time, reperfusion back at your transplant center, for some of the benefits, Dr. Osho, you mentioned.
yeah.
How far are we from that kind of
I
model?
I think we're very close. So that the jump we had to make, and which the Vanderbilt group has helped us do, but all that work is going simultaneously with ours, was whether or not you needed to put a BCD heart on immediate perfusion. And that jump has been made. The answer is no.
Hmm.
If you've got a good heart and a short ischemia time, at least from what we know from that paper, that then you have an option that involves simply protecting the heart that the way that somehow, and then preserving it in any of the standard ways that you use. Their preservation methods, for the transport were not particularly complex. It was simply a temperature controlled storage method. Um, but where we differ is what you use for that initial sort of protection,
Mm.
for the initial arrest of the heart, if you would. And our work simply used cardioplegia, um, and then it rinsed the to UW for the storage period. And theirs is got a solution that's a bit more complex, that has some blood but also has cardioplegia and is oxygenated, and so on and so forth. So now the comparison is perhaps there, and that is 6 months in the lab to get to that. So
Wow.
I think we're really close, certainly closer than I thought we would be at this point.
So what are the next steps?
Yeah, yeah, yeah. Dr. Tessier, I'll let you start it.
Um, I mean, Dr. Osho did a really great job of sort of summarizing some of the key differences in the Vanderbilt protocol versus this one. And I think, some important next steps are really to understand, um, is blood needed during cold storage? It seems they had some really good clinical outcomes. And like I mentioned, Dr. Rabi is also sort of starting to do transplants. I think he's done 3 now or maybe more um, in Canada with what my understanding is a similar approach. I think the major questions that I still have, and Dr. Osho and Dr. Rabi and I have sort of, talked through some of these already together. Is this if blood is needed? I think it's a really important question that we need to understand. I think there were also other additives included in the Vanderbilt's approach. They had some antioxidants, which I think would be really interesting to understand the role of the antioxidants. Antioxidants are commonly used in preservation, so it's not sort of a shock that they're there, but it would, these sort of differences, I think, still value some scientific support that they actually help the organ. Um, So I think for us, what we would like to do is try to tackle in particular that blood versus no blood question. I think we have some unique tools to be able to do that. So, like I mentioned, we have this sort of laser-based approach that allows us to look at the function of mitochondria, but not just the function on the mitochondria. Like, what is their demand for oxygen? Do they have enough oxygen or do they not have enough oxygen? And so we can try to ask questions like that to understand the role. I think there were other additives. I think theirs is heparinized, right? Their flush and
That's
their
right.
solution is heparinized.
It's blood. 2 liters of delnita cardioplasia. I think they had mannitol and steroids,
Mm,
solumedrol, and they had paralytic in there, rocuronium, and antibiotics,
right.
a couple of different types, levothyroxine. So it really is a cocktail of a lot of things, and the whole time it was being infused with 100% FiO2 inspired oxygen for a specific duration. In that 5 minutes, maybe 12. But the question is what of that entire cocktail is necessary? There's no way that you need all that stuff. Absolutely not. So simple science can just start to remove bits of this and see what actually counts. But I also think that as we think about next steps, I don't think that the debate or discussion of perfusion is done. I do think that we still have a lot to learn about exactly what type of perfusion, what is necessary in the perfusates, what temperature, cellular versus acellular, will actually help us to extend things. Because I think with this work, we're still talking about, preserving hearts up to 8 hours. I don't know that we can get much further than that without actually actively perfusing the coronaries.
Yeah. And I think just to add on to that too, I think, these initial clinical studies use, minimal cold ischemia times for obvious reasons. And so I think kind of anchoring this conversation back in what we were already talking about, which is really what is the sort of maximum duration of this, and to Shauna's point, like at what point is cold ischemia too much cold ischemia and we need NMP or other warmer methods or other therapeutics or other sort of interventions that we need to add into the cocktail to decrease that cold ischemia stress. So I think that's also another important question here is how far can we go using these sort of this new sort of DCD hypothermic paradigm? Like how far can we go, or how much tolerance to cold ischemia do these DCD hearts have? And I think that's a fundamentally important question that we need to answer before this can sort of make it to the, the larger clinical standard.
Mm.
And perhaps a bit of a tangent, but that I think is very much in the line of what's exciting is some of Dr. Tessier's work. And not to set you a spot here, but I do find the work with partial freezing so incredibly exciting. And this is how you truly get to be able to pull one of these things off a shelf to do a transplant. So, you want to talk a little bit about that?
Yes.
Yeah. So I guess there's a couple of things that, this sort of tolerance to cold ischemia, and how far can we push things if we just stay at 4 degrees C. And we actually also have some what we're calling sort of biostasis agents, where we are trying to actually get the organ to need less oxygen without sort of having to use deeper storage temperatures. So in other words, you use temperature to sort of slow metabolic rates in a very sort of simplistic way, at least describing it in a simplistic way. So we have these sort of therapeutics that we're using that will try to slow that metabolism even further beyond what would be possible with temperature effects alone. And so you can imagine just by keeping at the same temperature, you could extend that tolerance to cold ischemia even longer. The other way of doing that is what Dr. Osho mentioned is, to push to even deeper storage temperatures, pushing into the sub-zero range, which is, we have technologies in that space too, including, supercooling and partial freezing, where you store the organ in a liquid state, but below the freezing temperature for supercooling, and then actually encourage ice formation around the organ to try to preserve it in a partially frozen state. mimicking some of these sort of animals in nature that survive, freezing their whole body, and then reanimating months after storage or months after suspended animation. So again, sort of really pushing that paradigm and what might be possible in that cold space.
Fascinating.
It really is. It
Mm.
really is. What's some of your next steps on that research, Dr. Tessier, and how long do you think it might take to see a translation to the clinic for that?
Yeah, so for our sort of biostasis agents, we did a this work will come out soon, actually. I think so we did a pretty high throughput screen, and it was interesting the molecules that we picked out that could sort of mimic this, enhanced tolerance to cold ischemia without pushing to colder temperatures. So this is all in sort of 4 to 8 kind of range. And it's very interesting that a lot of those molecules that seem to work well, we've tested them now in our small animal model. And so the next step is definitely taking that forward to our facilities with Dr. Osho and sort of testing those in our large animal and showing sort of transplant success, which is definitely the next step. But the interesting thing about these molecules are that a lot of them are sort of naturally occurring molecules that are, already in the cells. So there's probably a pretty fast path for approval in terms of safety. And so those are sort of some next step that we're really excited about. I think on the sort of deeper sub-zero temperature ones, in particular, our partial freezing protocol, we were not in heart, but we showed with my mentors and collaborators, we also were able to show that we could partially freeze livers and kidneys as well. For the kidney model, we did show in a short-term transplantation model with a pig some transplant success after preserving those kidneys for 10 days. So there's some successes there in terms of a short-term transplant model. But I think just like all of our other work, the bar is really to show that we can do this safely and show successful transplants. And so we are, forwarding that both on liver and kidney, and then also with hearts. So that's the next step, is to really show that we can show long-term survival
Incredible. You said 10 days of storage, the kidney?
for kidney.
That's
Yeah, so
incredible. Congratulations. Wow.
thank you.
One of the things that I love about transplant is the concept of it being a team sport, and obviously during the actual preservation and transplant is definitely a team sport across the OPO, surgeons, medical directors. But the conversation we just had kind of extends that idea, that how really a team sport it is, from the importance of scientists and surgeons working together to figure out what's next, because we need to be hearing different perspectives. Our team oftentimes, kind of similar to what the both of you were talking about, is spends a lot of time making sure we can make things simple. At 2 a.m., I don't think anybody wants to be doing a science experiment in the middle of the country. And it's really hard. And so I think the kind of the critical questions that you kind of laid out, multiple times throughout this conversation are really the key questions.
I think it's, the point that you're making about the importance of, surgery being a team sport. I'll let Shauna talk on that. But in terms of the science,
Right.
The field of experimental transplantation is also very much a team sport. I mean, I would not be able to do the research that I do if I did not have, Dr. Osho and Dr. Rabi, and just this incredible team of trainees who, like you said, show up for long, difficult days. These are, there's no experiment that can be done just one person. So you're not pipetting by yourself at a bench. It takes a team of people to show up every day. Those people need to rely on each other. They need to work together. They need to have conversations about what's going wrong, because things always go wrong. And so it's funny, I was thinking back on when you were saying that one of our trainees, when we were starting up this program with Dr. Osho and Dr. Rabi, and I remember she came into my office one day and she goes, "Why are there so many people here?" Like, every experiment has so many people. And it's true. Like, if you come to some of our experiments, there are, 5, 6 people doing the experiment and people who just want to come and be involved and learn and take samples. And so it really is quite a lively, environment. And I think that is just so exciting to me. And it's the best part of experimental transplantation. But I'd like to hear what Dr. Osho thinks as well.
Well, I said I wasn't going to cry today, but Shannon said all those wonderful things, and it's so true. We couldn't do this without her. I think one of the bits of evidence of team science is how much we're still working with Dr. Ravi now, for example. I mean, he's in a different country, in essence, and contributing to the work that we're doing as he builds his new lab there. But and this segues into some of the exciting stuff that's coming out soon. But we've got collaborators across the world now. We've done some work already with some labs at UMass and some folks at BU and are exploring things with people as far as Australia and New Zealand. So it really, really is just exciting how embracing team science can expand horizons, can speed up the discoveries that we make. Really, really incredible. But I have to say that I'm so incredibly thankful for Shannon's Dr. Tessier's partnership here. It's just often she feels like an extension of me, and then I hope I appear that way for her as well. But we each get pulled in so many different directions, and perhaps me worse, getting called in the operating room or having been up and being able to continue the work through Shannon even at those times. It's just it's a blessing. So I said I wouldn't cry, but here we are.
I think that's what I love about transplantation. It's that concept of team sport and collaboration also extends in our teams. Our teams are structured where we have the heart, lung, kidney, liver teams literally sitting together, and so it's a matter of getting up and asking the counterpart above or below the diaphragm, hey, what's the latest, hottest research? And that allows us to really move fast. And it sounds like something similar kind of from what you were just saying, Dr. Tessier, from some of your, awareness of what's happening in the kidney and liver kind of preservation space.
Yeah, I think it's a great point. I think, communication across organs is also really important.
Yep. Well, just to wrap it up, Dr. Osho, Dr. Tessier, thank you so much for your time today. Are there any events, conferences, or upcoming publications that you are really excited that you'd like to highlight for our listeners?
Dr. Tessier?
I want me to start. Okay. A couple of conferences that are coming up. So in April, we have ISHLT that will be in Toronto this year. So we're really looking forward to that conference. We also are going to be hosting in Boston the ATC conference in June, I believe that one is. So both of our teams will be represented at those conferences. Did I miss any others, Shana?
Those are the big ones.
Okay, well, like I said, thank you so much for your time. We really appreciate everything that the both of you, as well as the broader Massachusetts General Hospital community, is doing to help advance the field. Thank you so much.
Thank you for your time
Thank
and
you
for
for the
hosting us.
opportunity. Yeah, thank you.